Hello everyone and welcome to our first module on stroke. Stroke is the acute onset of ischemia to the brain, and some people call it a brain attack because it's similar to a heart attack when there's the sudden onset of ischemia in the heart. It's called stroke because patients appear struck down by their symptoms, and the symptoms of stroke are the sudden loss of neurologic function. The symptoms vary based on anatomy, but it could be sensory loss or motor loss. And if the symptoms resolve in less than 24 hours, we call that a TIA, which is a transient ischemic attack. If the symptoms last more than 24 hours or persist indefinitely, that's what we call a stroke. Risk factors for stroke are shown in this slide. Hypertension is the strongest risk factor, but other risk factors are diabetes, high cholesterol, and smoking, and these are the same as the risk factors for coronary artery disease. TIAs and strokes can be broken down into two subtypes based on the etiology. The most common form is ischemic. About 80% of strokes are ischemic, and as the name implies, in these strokes the cause is insufficient blood flow to an area of the brain. There are three mechanisms by which ischemic strokes can occur: thrombosis, embolism, and hypoperfusion, and we'll talk about all three of these in the next two slides. The less common type of stroke is a hemorrhagic stroke. Only about 20% of strokes are hemorrhagic, and these strokes represent bleeding in the brain. They're sometimes called an intraparenchymal hemorrhage. And these strokes usually have a sudden onset. They begin when the bleeding begins, and then the symptoms increase gradually over the next few minutes or hours. And so the history in patients with strokes often gives you a clue to the subtype, and a patient with a sudden onset of symptoms that increase gradually over time, that's how hemorrhagic strokes tend to present. And it's very easy to distinguish ischemic from hemorrhagic strokes by doing a non-contrast head CT, which is the standard initial test in patients suspected of having strokes. In an ischemic stroke, there will be an area of the brain that is dark, otherwise known as hypodense, as shown in this image on the screen. What's happening is in this area of the brain there is edema because of cell death, and that edema changes the intensity of the brain in CT imaging, and therefore it appears darker than the surrounding tissue. In a hemorrhagic stroke, there's blood in the brain, and blood is bright, otherwise known as hyperdense. It looks like this image shown on the screen here. And because blood is bright on CT scan, it's very easy to identify, and it's also very easy to distinguish a hemorrhagic stroke from an ischemic stroke where the tissue is dark. As I said, there are three causes of ischemic strokes. The first one is thrombotic. A thrombotic ischemic stroke means there is local in situ obstruction of an artery. This is often one of the large vessels in the brain, vessels like the middle cerebral artery, the anterior cerebral artery, or the vertebral or basilar arteries. You can also have a thrombotic stroke from small vessel disease. These are called lacunar strokes. And then the second video on strokes, I talk about all these different subtypes in greater detail. But in terms of clinical presentation, thrombotic strokes often present with fluctuating symptoms. Patients can have normal neurologic function and then abnormal. They can have periods of improvement and then decline. A clinical history of neurologic symptoms that are waxing and waning over time, that's consistent with a thrombotic stroke. The second way you can have an ischemic stroke is from an embolism. These are called embolic strokes. If you have a clot elsewhere in the body that breaks off and travels to the brain, that causes an embolic stroke. And clots commonly form in the heart in patients who have atrial fibrillation or patients who have a left ventricular thrombus, and these clots can cause an embolic stroke. The other common source of an embolic stroke is an artery-to-artery stroke. In the carotid artery, plaque can rupture and thrombus can form and pieces can break off and embolize to the brain, causing an embolic stroke. The classic finding on imaging of the brain in a patient with an embolic stroke is that multiple territories will show ischemia. These clots typically shower the brain and cause ischemia in multiple different areas of the cortex. And in terms of symptoms, embolic strokes usually present with a sudden onset of symptoms. As soon as those embolisms reach the brain, the symptoms begin immediately, and then the symptoms may wane over time. This is the clinical course of embolic strokes. And then the last mechanism of ischemic strokes is hypoperfusion. This occurs when patients have hypotension for whatever reason. So a patient who develops cardiogenic shock can have an ischemic stroke. The cause is not thrombus or embolism. The cause is simply underperfusion of the brain. If you think your patient is having a stroke, the best first test is a non-contrast CT of the head, provided the patient is stable. And the reason this is so important is because of what we talked about before. It allows you to see whether or not there is hemorrhage. If you get a finding like what's shown on the screen here, then you know your patient has bleeding in the brain, and that is managed in an entirely different way than patients who do not have bleeding in the brain and just have ischemia. The most accurate test is called diffusion-weighted MRI. Diffusion weighting is an MRI technique that is very sensitive to detecting water. And remember what I said, in ischemic strokes, there are areas of edema in the brain, and diffusion-weighted MRI can pick those up better than CT scan. And this is especially useful in patients who have had small infarcts, who have a TIA. So when patients have a TIA and their symptoms resolve, the head CT may be normal, but if you do a diffusion-weighted MRI, you can see small areas of infarction, and that can let you know which vessels were involved in the TIA and what the mechanism of the TIA was. So the way you make a diagnosis of TIA or stroke is to find an infarct on imaging consistent with symptoms. If symptoms resolve in less than 24 hours, we call that a TIA. If symptoms last 24 hours or longer or persist, we call that a stroke. Let's focus on TIA now and talk about stroke risk. So a TIA is a medical emergency because a TIA is often a harbinger of a stroke that's about to happen. Patients who have a TIA, even though their symptoms get better in less than 24 hours, they have a very high risk of stroke going forward. About 8% of those patients have a stroke within a month, and about 10% have a stroke within 90 days. And in many cases, the stroke occurs within hours or days of the TIA. So patients with a TIA are often hospitalized and observed and started on medication to try and reduce the risk of stroke. And so that's a nice segue into the management of TIA. So a patient who has a TIA no longer has any neurologic symptoms because the symptoms resolved within 24 hours. That's the definition of TIA. So your goal in these patients is to prevent a stroke because they're at very high risk of stroke. So how do you do that? Well, this is done through secondary prevention. The mainstay is aspirin and statins, and some people use the mnemonic to remember this: strokes need statins. You also need to control their blood pressure and their blood sugar if they have hypertension or diabetes. You should counsel them to quit smoking if they're smokers, and they should be counseled to eat a healthy diet and exercise. And once again, you do all these things here because there's a very high risk of stroke following TIA. So TIA is somewhat easy to manage because the neurologic symptoms have resolved. Stroke is totally different because in patients with stroke, you are treating them while their neurologic symptoms are ongoing. And if you take appropriate action, you can often make those neurologic symptoms better. The key decision that you must make in a patient who presents with a new onset of a stroke is it hemorrhagic or non-hemorrhagic? And to figure that out, you need to do the head CT. If the patient has a hemorrhagic stroke, then you cannot use thrombolytic drugs. They are contraindicated. The treatment for hemorrhagic strokes is to reduce the blood pressure, reverse any anticoagulants the patient may be taking, and surgery in cases of massive brain bleeding. If, however, the stroke is non-hemorrhagic, then you have to consider thrombolysis because this therapy, if instituted quickly, is potentially life-saving and can resolve neurologic defects that would otherwise become permanent. And so in the emergency room, in a patient with a non-hemorrhagic stroke, what you want to think about is this patient a candidate for thrombolysis? All these other things I've shown on the screen here have no role. There's no benefit to heparin or warfarin or antiplatelet drugs during acute stroke. They have some role later in prevention of recurrent stroke, but no role in the acute management of a patient with a new onset stroke. Thrombolysis in ischemic stroke refers to the administration of tissue plasminogen activator, which is called alteplase. It's a thrombolytic agent that will break up clots and potentially restore blood flow to ischemic areas of the brain. It carries a high risk of bleeding complications, and therefore it's only administered during the period when it's most beneficial to stroke patients. And studies have shown that that period is within 4.5 hours after the onset of symptoms. It used to be thrombolysis was only administered in the first 3 hours. New studies have shown it has benefit out to 4.5 hours. So one of the most important things to determine when a patient presents with a stroke is when did symptoms start. If they began 10 or 12 hours ago, then there's no benefit to thrombolysis. If the symptoms are new within the last 4 hours, then thrombolysis may be indicated. Once you identify that the patient is in the window where thrombolysis is an option, you need to decide whether they have any contraindications. And all these are things that make the bleeding risk of thrombolysis so high that it's not indicated. There are lots of different contraindications for thrombolysis, but I've listed the most important ones on this slide. So the patient cannot have any active internal bleeding, obviously, because that would make thrombolysis way too dangerous. If the patient has ever had an intracranial hemorrhage of any type, they cannot get thrombolysis. The patient cannot have had an ischemic stroke or head trauma in the last 3 months. And then the blood pressure cannot be over 185 over 110. And we'll talk more about this in a minute, but many patients having strokes are hypertensive. And if the blood pressure is too high, then the risk of thrombolytics is too great. And then other things that increase the bleeding risk are also contraindications, things like low platelets, an elevated INR because the patient is taking Coumadin, or a prolonged PTT for any reason. So most emergency rooms have a checklist with all the contraindications. So once you determine the patient is within the window where thrombolysis is of benefit, you run through the checklist, and if none of these elements are present, you can safely administer thrombolytics. Let's talk about the management of blood pressure in patients having an ischemic stroke. Lots of patients with ischemic stroke present with hypertension. Over 60% of patients will have an elevated blood pressure when they present to the emergency room. As I just mentioned on the last slide, if you're going to administer thrombolysis, the blood pressure needs to be less than 185 over 110. If it's higher than this, the risk of intracranial bleeding after thrombolysis is too high to safely administer the drug. If you're not going to administer thrombolysis, the goal is different. The goal is less than 220 over 120. This is called permissive hypertension, and let's talk about why that's the case. It turns out there are collaterals that can supply blood to ischemic areas of your brain, and those collaterals benefit from a higher blood pressure. So for this reason, if patients are not going to get thrombolytics, you can allow permissive hypertension and allow the blood pressure to get as high as 220 over 120. When the blood pressure is too high in patients with strokes, we usually treat them with intravenous rapid-acting medications. Some of the options include labetalol, which is a beta blocker, and nicardipine and clofidipine, which are calcium channel blockers. Now let's switch gears and talk about hemorrhagic strokes, which are also called intraparenchymal bleeds because they represent bleeding into the parenchyma or the tissue of the brain. As I mentioned earlier, these usually present with the sudden onset of neurologic impairment, and because there is bleeding into the brain, this can lead to elevated intracranial pressure. I talk about intracranial hypertension in another video, but all the elements of high intracranial pressure can occur in patients with a hemorrhagic stroke. These are things like headache and vomiting and papilledema. And just like there are numerous mechanisms by which an ischemic stroke can occur, there are also several mechanisms by which hemorrhagic strokes can occur. One of the most common ones is an ischemic stroke that transforms into a hemorrhagic stroke after reperfusion. We'll talk more about this in a few slides, but a stroke that is initially ischemic several hours or days later can lead to bleeding and convert to a hemorrhagic stroke. Another common mechanism of hemorrhagic stroke is hypertensive vasculopathy. This occurs in patients with poorly controlled hypertension. They have small penetrating arteries of the brain that rupture. These usually lead to small areas of hypertensive stroke. A third mechanism is cerebral amyloid angiopathy, which I'll talk about in just a minute. And then lastly, patients rarely have vascular malformations in the brain, and one of these can rupture, causing a hemorrhagic stroke. Cerebral amyloid angiopathy is a disorder of blood vessels in the brain that causes recurrent hemorrhagic strokes. It usually occurs in elderly patients over the age of 60. In this disorder, beta amyloid deposits in the walls of blood vessels, and that makes them weak and prone to rupture. Beta amyloid is a collection of proteins. It accumulates locally in Alzheimer's disease in neurons, and when it accumulates locally in blood vessels, it causes cerebral amyloid angiopathy. These patients usually develop spontaneous lobar hemorrhages, so they will present with the abrupt onset of intraparenchymal bleeding in the frontal, parietal, or occipital lobes. Usually these are smaller strokes that only involve a small area of the brain, and this differentiates them from the large vessel ischemic strokes we talked about earlier. And also the fact that they occur in the lobes of the brain is different than hypertensive strokes, which usually occur in the basal ganglia. The diagnosis is made by imaging that shows multiple hemorrhages, so a patient who has multiple hemorrhagic strokes in the lobes of the brain over the course of a few months or a few years is usually presumed to have cerebral amyloid angiopathy. The definitive diagnosis requires a tissue biopsy, which is not usually done. And there's no special treatment for this. It's just a condition that places patients at high risk for recurrent strokes. The only thing that needs to be done in terms of treatment is these patients really should avoid anticoagulants. So I have a number of patients with this disorder who have atrial fibrillation, and we do not treat them with anticoagulants for atrial fibrillation, even though we normally would, and that's because we don't want them to have any additional hemorrhagic strokes. Earlier we touched upon the diagnosis and management of patients with hemorrhagic stroke, but let's talk about that in a little bit more detail now. The diagnosis is with a non-contrast head CT, or in some cases an MRI. As we talked about earlier, a non-contrast head CT will show white areas in the brain when there is blood present. The first element of treatment is to stop antiplatelet or anticoagulant drugs. Many patients with hemorrhagic strokes are taking anticoagulants, often for a history of atrial fibrillation. Blood pressure control is a major element of treatment of hemorrhagic stroke. I told you earlier that in ischemic stroke, we often allow the blood pressure to be higher because it can be beneficial. That is not true in hemorrhagic stroke. In hemorrhagic stroke, you want to bring the blood pressure down. Many patients are hypertensive when they present, so you don't want to bring it down too fast, but you try to aim for a target mean arterial pressure of about 110. And you can use the same intravenous drugs that we mentioned earlier, like labetalol and nicardipine. And then lastly, you have to worry about elevated intracranial pressure in these patients. If it's present, you need to treat it. And I talk about this in detail in the video on intracranial hypertension. And then I mentioned this earlier, but I just want to emphasize this point because it's important. Hemorrhagic strokes can occur due to hemorrhagic transformation of a stroke that is initially ischemic. This will present as worsening symptoms hours or days after a patient develops an ischemic stroke, and you need to obtain a repeat CT scan anytime a stroke patient has worsening symptoms. And one of the reasons for that is because although the initial stroke may have been ischemic, it can convert to a hemorrhagic stroke. After patients have been diagnosed with a stroke or a TIA, there are 3 standard tests that are usually done because they will change the long-term management of the patient. None of these tests are urgent and they don't take precedence over the head CT and treatment of the stroke in the emergency room, but usually at some point later, once the patient has been stabilized, the 3 tests on this screen are done. The first one is an EKG, and the reason you need to do an EKG in patients with stroke or TIA is because you want to identify atrial fibrillation. Any patient who has a stroke and atrial fibrillation on their EKG needs anticoagulation. And because atrial fibrillation can be paroxysmal and it can come and go, patients who don't have atrial fibrillation on their initial EKG are often referred for ambulatory EKG monitoring. This test involves placing 2 leads on the chest and wearing it for about a month to look for episodes of atrial fibrillation that may come and go. The second important test to do is an echocardiogram. That's because if it shows a left ventricular thrombus, the patient would need anticoagulation. In addition, many patients with strokes have a patent foramen ovale, and in some cases, those are closed surgically if it's thought that the patient's stroke was caused by a venous clot that broke off and crossed the PFO to enter the arterial circulation and reach the brain. And then the last test is a carotid ultrasound, because if patients have significant carotid stenosis, surgery may be indicated. I'll talk about this later in this video, and I talk about it in detail in the cardiology video on peripheral vascular disease, but surgery for carotid stenosis is considered if the stenosis is more than 70% in patients who have had a stroke or a TIA. And surgical management of carotid stenosis has no benefit during the acute stroke episode. This is not like angioplasty for myocardial infarction, where it's done emergently. Patients who have carotid stenosis usually recover from their stroke, and then days, weeks, or months later will have surgery for carotid stenosis. And I just want to re-emphasize that none of these tests are really important components of the acute management of a patient who comes in with a new stroke or TIA, but they are usually done at some point later, and that's because the findings can change the long-term management. Let's talk about stroke in young patients, which refers to stroke in patients under age 50. This is very uncommon, and when it occurs, you have to consider that there may be something going on other than plain old atherosclerosis and hypertension. The first thing you have to consider is a hypercoagulable state. So there are many causes of hypercoagulable state. I've listed some of them here. These include a factor V Leiden mutation, a protein CRS deficiency, or the presence of the antiphospholipid syndrome. And many patients with one of these abnormalities initially present with a stroke at a young age. Vasculitis can lead to a stroke at a young age, and then as I just talked about on the last slide, the presence of a patent foramen ovale is associated with an increased risk of stroke, and sometimes surgery is done to close the PFO. Endocarditis can cause a stroke in a younger patient, so you need to evaluate them for signs and symptoms of endocarditis. And then lastly, cocaine is a powerful vasoconstrictor. It's associated with myocardial ischemia, and it's also associated with stroke. The management of patients after a stroke is the same management as for patients who have had a TIA. All patients should receive aspirin. If they're allergic, they can be treated with clopidogrel. Aspirin should be started within 48 hours of the onset of the stroke, and if you administer thrombolysis, you need to wait at least 24 hours after thrombolysis before you give the first dose of aspirin. For patients who have evidence of atrial fibrillation, anticoagulation is more important than aspirin. Usually those patients who have AFib and a stroke will receive both anticoagulation and aspirin, although if the bleeding risk is high, sometimes the aspirin will be eliminated and the patient will only receive anticoagulation. Beyond these things, all patients should be treated with a statin. They all need control of their blood pressure and blood sugar, and they should all be advised to not smoke, to eat a healthy diet, and to get exercise. Mechanical thrombectomy is an alternative to thrombolysis that's becoming increasingly popular, so you should be familiar with it. It involves inserting a catheter into a large intracranial artery, and then the thrombus is removed mechanically. This is an image of what it looks like on the screen here. The coil collects the thrombus, and then you can suck it back out of the artery. And this can be done in centers that have the capability to perform the procedure in patients with ischemic stroke within 8 to 12 hours of onset of symptoms. I'll finish with one slide on carotid artery disease. As I said, I talk about this in more detail in the cardiology section in the video on peripheral vascular disease. But carotid artery disease is considered symptomatic if it has led to embolization, meaning stroke or TIA, within the past 6 months. And this is why a carotid ultrasound is a standard part of the evaluation of a patient who has had a TIA or stroke. Some patients have a complete occlusion of the carotid artery, and these patients get medical management only. These patients usually have collaterals that are supplying the brain on the side that is occluded. In a patient with a 70 to 99% carotid artery stenosis, those patients are usually treated with either surgical carotid endarterectomy or carotid artery stenting. In the 50 to 69% range, only men are treated because they are at the highest risk of stroke. They are treated again with either carotid endarterectomy, which is surgery, or stenting. Everyone else, meaning women with a stenosis 69% or less, or men with a stenosis 49% or less, are treated medically. And by this I mean all the things we talked about a few slides ago: aspirin, statin, blood pressure control, and blood sugar control. And that concludes our first video on stroke.